Thank you.
Thank you. So thank you very much for the invitation to share the results with you today. I'll go through the background and methodology of the trial, and then Prof. Davies will talk through the results and the implications. So as you're all aware, venous ulceration is a challenge to treat with poor assessment and low healing rates, resulting in a great source of discomfort for many patients. And as you've already heard, it's expensive. So the national guidance in the UK from NICE recommend that patients are referred from their GP to a vascular specialist after only 2 weeks, and that a duplex is performed to confirm the diagnosis. Yet despite this, patients often suffer from delays in referral, leading to chronicity. The standard care in the UK involves compression bandaging to heal the ulcer, followed by surgery to correct the underlying venous reflux. And as you've already heard, this is derived from the EVRA Study, which shows that surgery reduces the risk of recurrence. It did, however, not show any difference in ulcer healing. There were several limitations to the EVRA study that may have affected the ability to adequately assess the effects on ulcer healing. So firstly, nearly a quarter of the patients randomised to surgery refused to attend for their operation. The study wasn't powered to assess ulcer healing. It included ulcers, both healed and open ulcers, and on average, patients waited 7 weeks for intervention, so they didn't receive an immediate benefit. And some of the procedures were ligation under local anaesthesia, meaning that residual reflux may have been left. There have also been some subsequent cohort studies using foam sclerotherapy, which has showed that ablation of the main truncal reflux can enhance ulcer healing. So based on this, we designed the randomised control EVRA study. We wanted to provide level 1 evidence as to whether endovenous ablation should be offered prior to ulcer healing. When we designed the study, we wanted to make sure that patients were involved in the design. So this is a photo of our trial team with Bruce, our PPI rep to the right there. He helped us design the study by sharing his leg ulcer care and also his experiences being referred from primary to secondary care. And he sat on our trial steering committee throughout the study and advised us. We also ran a focus group when designing the study of patients with active leg ulceration, and this helped us determine 2 important things. So firstly, that time to ulcer healing was the most important outcome for them. They wanted that ulcer gone, and they wanted it gone quickly. And secondly, that they'd be willing to undergo early intervention. We didn't want to run into the problems that the ESCAR study did with the crossovers, so this reassured us. So according to the published literature out there, the 24-week healing rate at the time was about 60% in those randomised to compression alone, whereas those with early intervention, this could have been high as 82%. So for the trial, we wanted to detect a 15% difference between the arms. So incorporating a 10% dropout rate and some further allowances for crossovers, 450 patients were required to show this difference at 90% power. And in terms of the number of healed leg ulcers, we needed 254. So the inclusion criteria is summarised here. It includes patients with an active leg ulceration between 6 weeks and 6 months in duration, no significant arterial disease, and who were considered suitable for endovenous ablation as determined by the treating clinician. Leg ulcers of non-venous etiology were excluded, as were those conditions precluding interventions such as deep venous occlusive disease. So all of the trial patients had effective compression therapy, whether it was 2, 3 or 4 layer bandaging, hosiery or compression stockings. The wound care and dressings were all per local policy, and everyone was advised to wear the compression stockings once the ulcer had healed. So the only real difference between the arms were that the early arm had to have ablation within 2 weeks of randomisation, but the deferred arm had ablation once the ulcer had healed as per standard care, and we did allow for intervention at 6 months for those that had still not healed. So Isaac went through the different endovenous interventions. We didn't specify which one had to be used. We left it up to the treating clinician, but they did have to abide by some core principles to ablate the main truncal reflux to the lowest point of incompetence and then put the patients immediately in compression after intervention. So as mentioned earlier, the primary outcome was time from randomisation to ulcer healing, and we had some clinical and quality of life secondary outcomes and also a cost effectiveness study. So I won't go too into the stats, but the primary endpoint was determined by an unadjusted Cox regression, and then we used the recruiting centre as a random effect, whereas the ulcer-free time only included patients that had reached the 1 year, and that was assessed using an ordered logistical regression. So this slide just summarises the study. All patients were assessed clinically at 6 weeks in an outpatient assessment, and there was a duplex in the early arm to assess for patency. Quality of life outcome measures were collected at those several time points, and then ulcer healing was determined by photo verification visits taken by the research nurses. So recruitment took place between October 2013 and September 2016, and we recruited from the 20 vascular centres that you can see here. I just wanted to use this opportunity to say a big thank you to all the centres involved. Leg ulcer trials are notoriously difficult to recruit to, so it's only with the complete engagement of the principal investigators and the real hard work of the research nurses that we were able to achieve our target of 450 participants. And obviously thank you to everyone that took part, because we could not have done this without them. So during the recruitment periods, over 6,500 patients were screened, and that resulted in a 7% inclusion rate. So nearly a third of ulcers were excluded, as they'd had their ulceration for over 6 months in duration. 10% of the ulcers had healed by the time of randomisation, so they couldn't be included, and 7% of those approached declined to participate. Of the 450 patients randomised, 224 were allocated to the early arm and 226 to the deferred intervention arm. Again, due to the hard work of the nurses, we had a relatively low withdrawal rate, so 31 patients were lost to follow-up or withdrew, and over the course of the study, 12 participants died. So I'm just going to highlight some of the main baseline characteristics. You can see that there were slightly more men than women randomised. And the mean age was in the late 60s. The BMI is slightly elevated compared to the non-population. And if you look at the arms, you can see that they're very well balanced, in particular the proportion of patients that had had a previous DVT, and that was in the randomised leg. So with respect to the baseline ulcer characteristics, you can see again the arms are well matched. The baseline ulcer duration was 3.1 months, and the baseline ulcer size 2.7 centimetres squared. Just over half of the ulcers were recurrent, and you can see from the baseline compression, again, it really does reflect the real-world variability between all the regimens used. The baseline reflux incompetent patterns were fairly typical of a population presenting with venous ulceration, so this hopefully should ensure the results are generalisable. Again, the arms are balanced, and about a third of the patients had concurrent deep vein reflux. So now I'll pass over to Prof. Davies.
Again, thank you very much, and I trust you are enjoying the presentation so far. Now, the key outcome for which we were all wanting to see what actually was the effect with respect to ulcer healing, and as you know, we've got two groups, the early and the deferred treatment group. The early group is in orange, and the early group is in green, and the deferred group is in orange. At least that got you all to wake up slightly. And as you can see, there actually is a significant difference if you look at the unadjusted hazard ratio. So undoubtedly, there is a significant benefit from early endovenous intervention. If you then look at the 12 and 24-week rates, you can see again a significant benefit with respect to early intervention. The other thing that you will note is that compared to many other series, the compression arm did very well because the data is better, but again, even despite good results from compression, the early endovenous ablation gave you some even better results. If we look at the intervention with respect to whether it was foam, thermal ablation, or whatever technique was used, there is a benefit for early intervention, and there really was no difference between the techniques. If, as we commented, and Francine highlighted quite clearly the importance of ulcer-free time, again, you can see that there is absolutely a significant difference between the early and the deferred intervention. So, i.e., early intervention means that your patient has less time with a leg ulcer. If we look at the vein clinical severity scoring system, which is a system for evaluating the venous disease in the leg, you can see at 6 weeks there is a significant benefit for those that have early treatment. If we look at the standard measures of the Aberdeen varicose vein quality of life, the EQ5D, and the body pain domain of the SF36, you can see again quite clearly there is a statistical benefit for early treatment with respect to patients' quality of life. If we look at the timing of the intervention, and you have to remember we are working in a health service, and the ideal was that patients who were randomized early had to be treated within 2 weeks, and we managed that in 91% of the patients, and as you can see, 4% of the patients got their treatment between 2 and 4 weeks. If we look at the complications, there are complications in both arms, and it is important to note that the asymptomatic DVT rate was higher in the early intervention group. This was in one site to use a lot of foam, and these are what we think are chemical-induced thromboses, but they were exceedingly minor, but were actually documented by the people performing the ultrasound. So I hope I've been able to convince you that early endovenous ablation in this study shows that there's a shorter time to healing, and there is a reduction in the time that your patient would have ulcer-free time. But so what? Is it cost-effective? And we've already heard from the earlier speakers today how important cost and money is. Well, I'm not going to bore you with all the stats and methodology of how you do cost-effectiveness analysis, but this was an in-trial analysis. It looked at NHS and personal costs, the costs that would from the NHS for 2015 and 2016, and we calculated quality of life years from the EQ5D, etc. And there was a technique used called bootstrapping, and we looked at the cost effectiveness with respect to accessibility curves. So with respect to the two methodologies of deferred and early, you can see that obviously in the early group there is more cost with respect to trial procedures, whereas in the deferred group there is more money spent in primary and community care, and the rest are all roughly about the same. And if you're looking at the overall costing, you can see that the early group cost about £50 more. But if you then go into the science of health economics, and you can either take all of the data that we had on 345 of the completed cases, or you can use a technique where you use estimates and you do multiple imputation, you can get some values with respect to costs. And here you can see that really there is a significant difference between the deferred and early group. And if you look at this concept of the incremental effectiveness ratio, again, you can see a nice threshold. And remember, the nice threshold is 20,000. You can see that there is significant benefit using either of these two models. But to really represent that in graphic form, you can see the multiple imputation model and the complete case model. Now, any of you who have worked with NICE will know that if you have anything that really has a probability of over 60 or 70%, it is undoubtedly deemed to be cost effective and would be recommended by a guideline. Here we've shown that the early intervention is highly, highly cost effective, looking at this either 86 or 99%, depending on which of the two models you use. So what are the conclusions of this study? Well, the conclusion very clearly is that this is the first large randomized trial that has shown that early venous intervention does actually improve leg ulcer healing. And not only the healing, you have a longer ulcer-free time and is undoubtedly cost-effective. So what are the implications? Well, for me, it's fairly straightforward. That actually all these patients who present with a leg ulcer need a rapid assessment to see if they are suitable for venous ablation, and if they are suitable for venous ablation, they need to have that early on. If I was giving a talk to a group of community stroke nurses and stroke physicians, you would all be flashing up the words fast, and I would suggest to you we need something similar for legs. I accept it's not 24 hours, but we should just trade the 24 hours for 2 weeks. Undoubtedly, the study will have significant implications for guidelines in the United States and globally. The American recommendations, the present are a 2C recommendation, as Isaac highlighted to you. Undoubtedly, these will change. But actually, this is a good study. It's cost the government just under 2 million for us to be able to deliver. But the key thing is that we can actually educate the patients, nurses, GPs, and the commissioners to refer patients for early assessment, and it is all joined up. And actually, I think the one group of patients who are probably very stoical and don't shout are those patients with leg ulcers. Many of you will have seen the news yesterday that Theresa May has given 75 million for men to have their prostates evaluated. And I would suggest to you that 75 million, and even being male, would actually probably be better spent on leg ulcer evaluation than it would be on prostatic cancer. And we were very fortunate that the paper was published 2 days ago, but I hope it will have significant impact by actually proving to people that we've provided good evidence that these patients should be treated early, and we need to persuade our public health doctors and those people who are divvying out the cash that these patients will benefit and we will save them money if we get them early. Thank you very much.